fractures. That's because they're the most common fractures in children. Assessment of elbow fractures can be difficult because there's a changing skeleton in the growing body, and some of these fractures may in fact be very, very subtle. Injury to the elbow joint is usually due to a hyperextension or an extreme valgus deformity, which is due to a fall on an outstretched hand. When you're looking at elbow x-rays, there are a few things that you need to assess in order to determine whether or not there's an abnormality. The first one is looking for the fat pad sign. Now, it's normal to see an anterior fat pad. It's when you've got a positive fat pad sign is where you have a posterior fat pad, and this becomes obvious when you've got a fracture, even if it's very subtle. It's what's called pathognomonic of a fracture around the elbow joint. So as I said, anteriorly it's normal to have a fat pad, but posteriorly, even if you can't see an actual fracture line, it's very suggestive that there's a fracture, and the patient needs to have several other films in order to determine whether or not there's a fracture. On this film that I'll show you, when you get the email, it shows a very obvious posterior fat pad. But if you look at the normal bones on this x-ray, you can't see an obvious fracture. But you need to do other films in other views in order to determine whether or not there's any pathology. One of the other things that you need to look at on your lateral view is what's called the anterior humeral line. And this is taken with a line taken along the anterior surface of the humerus, and this line should pass through the middle third of the capitellum. If this does not occur, it means that there's an abnormal alignment and suggestive of an underlying fracture. This is an X-ray which shows a normal anterior humeral line. You can see it runs down the front of the anterior humerus, and it goes through the middle third of the capitellum. On these two views, I show at different stages of development. So even when the growth plates aren't intact, the anterior humeral line should still go through the capitellum. Now, what I'm not going to go through today, and you're free at your own leisure to go through yourself, is the appearance of growth plates. Now, around the elbow joint, there's a mnemonic called CRITOE, C-R-I-T-O-E, and it reflects the sequence of which the growth plate appears on the normal child's x-ray. The first being the capitellum. So that's usually present around 1 year of age, and so you should be able to see on an x-ray of any child greater than 1 year of age the capitellum, and therefore determine your anterior humeral line. This x-ray on the next film shows that whilst the fracture is quite subtle, if you look at this rule, you can see that this anterior line doesn't actually go through the middle third of the capitellum. In fact, it goes through the anterior third of the capitellum, so this is an abnormal alignment. And if you look more closely at the film, you'll actually see that this is a supracondylar fracture. It's an not very displaced fracture, but you can see that because that line doesn't line up, that there's a fracture there. The other line that you need to look at is called the radiocapitellar line. And again, it's taken on the lateral view. It's a line taken through the centre of the radial neck, and it should pass through the centre of the capitellum. And again, if you don't have this normal alignment, it's suggestive of some sort of fracture or underlying dislocation. On the slide that you'll be presented with, there's both an AP and a lateral view. And you can see that through the middle of the radial neck, you can see it dissecting the middle of the capitellum. This is normal alignment. The next x-ray that you'll see will show that when you draw a line through the middle of the radius here, it doesn't actually dissect the capitellum at all. And this reflects a dislocation of the anterior of the radial head. So, we've just spoken about 3 things that you need to check on the x-ray of the elbow in order to determine if there's underlying pathology. First is the presence of a posterior fat pad. The second one is looking at the anterior humeral line. And the third is the radiocapitellar line. So once you've got those, you can then go forth and determine whether or not there's any pathology. Supracondylar fractures account for about 60% of elbow fractures found in children. They're the most common. About 95% of these injuries are due to hyperextension when a child falls on an outstretched hand. If there's only minimal displacement or no displacement, the fractures can be really subtle or occult on the X-ray. And so it's really important that you look for those three signs that I was talking about. In particular, you'll get the positive posterior fat pad sign. And when you look at it very closely, there'll usually be some displacement of the anterior humeral line because it won't pass through the middle centre of the capitellum. It's these patients, which are called Gartland type 1 fractures, that only require a long arm plaster in order to immobilise that fracture. Gartland type 2 fractures show that there is some displacement of the distal fragment of the humerus, but the posterior cortex of the fracture still remains intact. It's this fracture that will require closed reduction. Now, some patients may be able to have a closed reduction and just a cast put on, but others may need actual percutaneous fixation, because a long arm cast may actually not hold this fracture in place once you have it fixed. I've also got a second picture of a Gartland type 2 fracture, which shows that the anterior humeral line is out of alignment, despite the fact that the fracture is not overtly obvious on the original film. Gartland type 3 fractures are very obvious. You've got complete dislocation of the distal fragment, and these fractures are at high risk of malunion and neurovascular complications. They require reduction, and this can be either a closed reduction or an open reduction. In most cases, stabilisation is achieved with either 2 lateral pins going through the distal fragment up into the humerus, or they may actually have a medial and a lateral that cross. And this is an example of the management of the type 3 Gartland fracture. I think the point I want you to get from this is that this requires orthopaedic intervention and needs to be done quite early. As I mentioned, the Gartland type 3 fractures, where you get complete dislocation of the distal fragment of the humerus, often involve neurovascular compromise. On this diagram, it shows that you've actually got the brachial artery and the median nerve that cross anteriorly at the joint, at the elbow joint. And so therefore, if you get angulation of any of your fragments, you've got potential compromise of these 2 vital structures. Some of the complications associated with a supracondylar fracture include those that are neurovascular. So you may get damage to your ulnar nerve, particularly if the fragment's displaced posteriorly, and you'll end up what's called an ulnar claw hand. If you involve the medial nerve, you won't be able to oppose your thumb. And if you remember, that's one of the key components of actually being human, our ability to oppose the thumb. So it's a vital function that needs to be preserved. You may actually get impingement of the radial nerve, and that'll cause a wrist drop. In severe cases, and this is not common but can potentially happen, if you get complete occlusion of the brachial artery, you can get what's called a Volkmann's ischemic contracture, and that will cause significant disability to the upper limb. Other things that you need to look out for as potential complications of supracondylar fractures include compartment syndrome, as well as more later complications such as malunion and non-union. And don't forget that actually treating these fractures may induce complications. So if the child has to go to theatre for an anaesthetic, for instance, you may well get complications from the anaesthetic. You may get complications from the child just being immobilised for a prolonged period of time. In paediatrics, it can be difficult to assess the function of the nerves of the hand, but there are 3 key things that you can get them to do in order to determine if you've got function of the nerves. The first one is called the OK sign, where you get the child to flex at the distal interphalangeal joint of the index finger, and you get flexion of the proximal interphalangeal joint of the thumb. If they're able to say, I'm okay, they've got good function of the median nerve. So opposition of the thumb and the forefinger. One of the other ones is the radial nerve, and you want them to give you the thumbs up sign, and you want them to be able to maintain the extension of the thumb. That means you've got an intact radial nerve. The last one is to give the starfish sign. So they spread their fingers apart like this, and you can't adduct the fingers together. This is testing the ulnar nerve. So 3 signs that you can easily elicit in children. I'm okay, thumbs up, and give me a starfish, which is the median, the radial, and the ulnar nerve. Don't forget the simple things that make a great importance in the emergency department and to determine outcome of this injury. Don't forget to offer analgesia to your patients. These are extremely painful fractures, so you may want to use titratable morphine or fentanyl, or you may actually need to give ketamine, particularly if your orthopaedic surgeon is keen on doing a closed reduction there in the emergency department. You need to immobilise the fracture. Fractures that are still flailing around in the wind are painful, and often providing support is really important in providing analgesia. If you think that your child is going to need to go to theatre, remember to start them fasting, so keep them nil by mouth. And don't forget to communicate with the parents. It's important. This is a very, very frightening time, both for the children and for their parents. The key to the management is to explain what is going on, what the treatment modality is, and what the likely outcome is. And don't forget, if you've got the Gartland type 2 fracture or the Gartland type 3 fracture, you want to get your orthopaedic surgeon involved quite early. One of the second most common fractures around the elbow joint in children are fractures to the lateral condyle. This usually occurs in children between 4 and 10 years of age. It occurs when a varus form is applied to the extended elbow. So again, usually when children fall on an outstretched arm. These fractures are actually intra-articular, and they're prone to non-union because the actual fracture is bathed in synovial fluid. The fracture fragments are primarily cartilaginous, and therefore they can be very, very difficult to find on the X-ray, and in fact may not be visible to you at all. The importance of determining whether or not they've got a lateral condyle fracture is determining how they'll be treated. If your fragment is greater than 2 millimetres displaced, they often need to go to the theatre for surgical reduction and fixation with K-wires. However, if you've got less than 2 millimetres displacement, they can often be treated in a long arm cast with the arm fixed at 90 degrees. Again, I'm sorry, Nandi, Labasa and Suba, but there are a number of x-rays here that clearly show where the fracture is on the lateral condyle. Again, when you've got growth plates involved, it can be really, really tricky. But I think the important take-home message is that this is the second most common fracture in the elbow joint of children. And so if you've got a child who's presenting with a painful, swollen elbow, you need to look specifically at the lateral condyle so that you can determine whether or not there's a fracture there. Again, it's much more obvious on this fracture, and you can see that there's more than 2 millimetres of displacement, and this child would need to go to theatre to have this fracture fixated. If it's not correctly managed, this child will be left with a chronic deformity which will result in quite severe disability. So this is a fracture that you don't want to be missing in your emergency department. Other types of fractures that are common in children that I want to discuss today are femoral shaft fractures. Now they can present in all age groups, but the etiologies of these femoral shaft fractures are different according to particular age groups. In children that present with a femoral shaft fracture between the age of 0 and 18 months, you always need to consider non-accidental injury. There's no particular fracture pattern that is specific for non-accidental injury, so what you need to do is make sure that you take an adequate history and ensure that it's compatible with what your fracture pattern shows and also the history that the parents are giving you. If children aren't yet crawling or they're not yet walking, you need to be very suspicious of how they obtained their femoral shaft fracture. It's actually very uncommon for short falls, such as rolling off a bed or rolling off a table, to actually cause a femoral shaft fracture. So if you have a child who's just got a simple mechanism of fall but a femoral shaft fracture, you need to keep in the back of your mind that this may actually be non-accidental injury. In toddlers, however, you can have quite commonly spiral fractures or even transverse fractures of the femur. And that's because at this age they've got changes in gait, they've got increasing mobility, and they've got greater climbing ability. They're also unfortunately exposed to traffic and can be hit by cars, which would result in a femoral fracture. After the age of about 3, you tend to get a decreased rate of fractures to the femur because they've got improved gait, they know that they probably shouldn't jump down off things, and they've actually got better bone strength. So after 3 years of age, a spiral fracture in a child is a bit unusual, and again, you need to take a good history as to what led to the fracture itself. But typically in a child under 3 that is just starting to toddle, any sort of torsional force can result in this spiral fracture and isn't necessarily due to non-accidental injury. In children and in adolescents, you can also get femoral fractures, and this is usually due to motor vehicle accidents. Now, this may be them being involved in car accidents themselves, but it may actually be them being hit by a car when they're on a bicycle, or it could be them hit by a car when they're a pedestrian. It's really important, though, that if you have a low mechanism associated with a fracture that you really don't think would involve quite enough force to cause a fracture, you need to start thinking about the possible underlying conditions such as an osteosarcoma or other bone malignancy that may have resulted in what's called a pathological fracture. So again, 3 groups of children that may all present with a very similar injury, but the etiologies are all very different. In children under the age of 18 months, you always need to be suspicious of non-accidental injury. In those that are starting to toddle, it isn't uncommon to result in a spiral fracture of the tibia. They may actually get a direct, the femur. Then they may actually get a direct force to the femur, which may result in a transverse fracture. But usually in the older child and the adolescent group, you're going to require quite a significant amount of energy in order to break that femur. And so if you've got a low impact sort of stimuli, you need to start thinking, is there anything else, such as a pathological fracture, that may have led to this? So despite the lead up to this talk, which was very prolonged, I actually haven't talked about too many things, but there are 2 take-home messages that I want you to take today. First of all, you need to know your elbow rules. You need to look and know that a posterior fat pad is pathological. You need to know your anterior humeral line. It needs to dissect the middle third of the capitellum, and anything that doesn't form into that alignment, you need to be suspicious of the supracondylar fracture. The next thing you need to look for is your radiocapitellar line. So you need to draw a line through the middle of the radius and see that it dissects the middle of the capitellum. If that alignment is out, you need to be very suspicious that there's actually a radial head dislocation. That can often be associated with fractures of the ulna. And hopefully in a couple of weeks' time, if Anne will allow me, I'll talk about a few other fractures that are difficult to pick up in the emergency department, but are very, very important. And one of them is radial head dislocations associated with an ulnar fracture. The other thing that you need to remember is that you always need to look at the lateral epicondyle if you're suspicious of pathology within the elbow. These are subtle. They often involve the cartilage, and so they might not be obvious on your first films. So you need to look for displacement of a fracture through the lateral epicondyle. These are important. If there's displacement greater than 2 millimeters, you need to get your orthopaedic surgeon involved. Because if you don't, you could result in severe disability at the elbow joint, which could impact, the future employment potentials of a child. Not employment as a child, employment as an adult. Remember that
I think you should be on television now.
And remember, there are multiple etiologies to fractures of the femur. Young children, the toddler, and then the adolescents. Now, my talk, it may never get to you. I'm hopeful, but it may never.
3 seconds.
But if you would like, there is a really, really useful website that you can all take down now. It's what I call Radiology for Dummies, and it's what I use. It's called Radiology Assistant. It's www.radiologyassistant.nl. It's from the Netherlands, it's in English, but it's Radiology for Dummies, which is what I need, because this is not my area of expertise, but it's important. It's particularly important for the diploma students. And I would suggest that you go and look at that website in the next few days and refresh yourself on common injuries that can be found in the paediatric population. Are there any questions that we can put forth to the floor?
My question is, can we quickly look at the X-ray? Can we quickly do the X-ray?
Okay. All right, can we go to the first slide?
I'm trying.
Oh no. So, this is normal, your normal anterior fat pad. It's often found without any pathology. However, on the next slide, you can see that that anterior fat pad is displaced more proximally, but you've also got the posterior fat pad. Now that X-ray itself doesn't show any obvious pathology, so you would need to do other views in order to determine where the fracture is.
So this is also known as the sail sign, because it looks a bit like a sail on a sailing boat.
It does. This is the anterior humeral line. And again, this is a line drawn down the anterior surface of the humerus through the middle third of the capitellum. Now, can you see on your slides there that that middle third is in green? So you want that line to go through. If you go to the next slide, Anne, you can see this on actual X-rays in different stages of development. So this is a more developed child on the left and a younger child on the right. And you can see that it dissects the middle third of the capitellum. The next slide shows abnormal anterior line. Now you can see on those X-rays though that you've already been given a hint that there's pathology, because you can see that posterior fat pad there on that initial line. But then you can see with that beautiful yellow line that that doesn't dissect the middle third of the capitellum. Next slide. This is the second line that you look at. It's the radiocapitellar line. Again, dissects the middle of the radius through the capitellum. Next slide. This is on normal radiographs, and you can see this radiocapitellar line both on the AP view and the lateral view. The radius should dissect the middle of the capitellum. Next slide. However, you can see that this is quite an obviously dislocated radial head. It's not dissecting the capitellum. Yeah. This is an obvious supracondylar fracture. Next slide. Sound like an idiot.
No, you're on television.
This is a Gartland type 1 fracture. Now you can't actually see the fracture line through this, but you can look at your elbow rules and see that the anterior humeral line isn't dissecting the middle third. But you can see that the cortex is not breached on either side. That's treated with a long arm cast and immobilization. Next slide. Gartland 2 is a fracture, but the posterior cortex there of the humerus won't be breached. This again will require reduction in order to maintain the integrity of the elbow joint. Next slide. And you can determine that there's a fracture there by looking again at your anterior humeral line. Next slide. This is much more obvious to all of us. There's complete displacement of the fracture line. You can see that the proximal humerus is dislocated anteriorly, and this can possibly cause neurovascular compromise. Next slide.
I guess the other thing to note about the artery there is that often it's just in spasm because it's actually sort of stretched. So if you actually do improve the alignment, then usually they'll get their pulse back. So important for them to go to theatre early for that reason that, obviously they don't want ischemic arm muscles for too long. Even if their artery isn't damaged, it will be stretched. Yep.
Often the children may present with a pulseless hand that's still pink with a good capillary refill. That's less urgent than the hand that presents completely white and ischemic. So as I said, Gartland type 3 need to be taken to theatre for these KYs in order to maintain the integrity of the joint. Next slide. And this is just a diagrammatic representation of how the fracture fragment can impinge on both the brachial artery and the median nerve. If you've got, I remember 95% of these fractures will show anterior displacement, but there is 5% of these fractures that may dislocate or displace posteriorly, and that's when you're most likely to get ulnar nerve involvement. Next slide. This is just a list of the complications of supracondylar fractures, and basically you need to just remember the function of those nerves that could potentially be involved. If you do the ulnar nerve, you're going to get a claw hand. Oh, again, you're going to get, and you can get potential ischemia, you can get compartment syndrome, and later on you may actually get non-union and malunion, which may result in a deformed joint. Next slide. This is testing the anterior interosseous nerve, which is part of the median nerve, and this is the I'm okay. The radial nerve is extension of the thumb, and, oh, that's not right. That should be ulnar. That's the radial nerve, and then the next one is the ulnar nerve, which is your starfish sign, and that's because the ulnar nerve supplies the interosseous muscles, which are involved in finger abduction of the hand. Yeah.
And make sure you have a blue cloth to hand.
That's the curtain in my hand, in my house. Again, it's really important in our role as emergency physicians to make sure that we have a positive experience for both the child and the parents, and that means giving early analgesia that can be titrated intravenously, or if you can't get an IV line, you need to go intramuscularly. But you need to provide analgesia for these very, very painful fractures. You need to immobilise the fracture as soon as you can, and if you think the child's going to theatre, keep them nil by mouth. Next slide. Now, these are the very subtle lateral epicondyle fractures. As I said, they're often part of the cartilaginous part of the joint, so they can be very subtle and difficult to detect. So it's something that you actively need to seek when you're looking at x-rays of the elbow joint. And you can see on this, there's a very, very small fracture line. That's minimally displaced in that it's less than 2 millimeters, and that can just be treated with immobilization and a plaster. This one, however, is much, much more evident, and you can see there's greater than 2 millimeters of displacement. This would need to go to theatre in order to be fixed with K-wires. Next slide. This is just going on to our femoral shaft fractures, and this is in a baby, and you can see that it's almost a transverse fracture. If this child was not walking or not crawling, this would be very, very suspicious of non-accidental injury, and this is something that you would need to get your paediatricians involved with as well. Toddlers' fractures can often be spiral due to torsional forces, because they're just learning how to walk and they twist and turn really quickly, and they can often result in these fractures. They're very uncommon as non-accidental unless the mechanism is not suggestive. So history taken from the parents is really important. And again, in the young adolescent, you need to think about the energy load that was delivered in order to result in the fracture. And if that energy load is not significant enough, then you need to start thinking about underlying pathology, such as an osteosarcoma. It's uncommon, but it's really important that you don't miss. And there on that summary slide, you can just see that I want you to know about supracondylar fractures, I want you to know about lateral epicondyle fractures, and I want you to know about femoral fractures. And for more information, you can go to that website. In a couple of weeks' time, if Anne's in agreement, I'd like to go over things such as the Galeazzi fracture of the forearm, which is the most commonly missed fracture in the emergency department. I'd like to talk about the Monteggia fracture. I'd then like to talk about fractures of some of your carpal bones, which can be really important, that of the scaphoid and the lunate, and then perhaps some foot fractures such as the talus and such as the Lisfranc joint. They're just some fractures that are commonly missed in the emergency department, and I think it would be important to go over all of those at some stage. But today, the take-home message is the common fractures in paediatrics. Any questions from any of those slides that you've now been able to receive? Crap, we've lost it.
Thanks, Mel.
Oh, okay, good. Thank
Still
you.
here. Thanks for being a good sport and doing it twice.
That's okay.
And of course, we'll allow you to do whatever you like in the future.
Okay.
However, we'll need to buff up our IT support in all locations to ensure we don't miss out. The other thing to note is next week's O&G, and the week after will be the exam.
Can we miss out on that week? Yeah.
So there'll be no Tuesday session during the written exams, and then the following week will be the OSCEs. So that will sort of be the end of the academic year, but we'll have a discussion about how we continue education anyway. I think regardless of whether diplomas or masters are continuing, we need to continue an education program anyway. So we'll have a bit of a discussion before next week about what our plan of action is from then on. Because I think it would be good to continue in some way. We just have to decide what the best time and way to get everyone connected is.
Okay.
Sound fair?
Thank you.
The other thing, diploma guys, I'll send around the answers to the last two short answer questions that I sent you all, and I'll also send you a bit of a mock OSCE, just one question. So Vishal asked about the format, but I'll send you so you know what to expect and how we'll mark it, and that might put you at ease a little bit, so you know what to expect. Okay?
Yes. Thank you.
But don't be scared.
Love you.
Thank you.
Okay, thanks guys, bye.
Love
Bye. Bye, Cara.
you. Love you, Rohit kar karte
Bye.